Welcome to Bed-Related Safe Patient Handling and Positioning for Post-Acute Care from SPAN Academy. These are our objectives in this course: to discuss and demonstrate the correct positioning of the bed for transfer of patients from stretcher to bed, to demonstrate configuring the bed for comfort chair, discuss and demonstrate the correct positioning of the bed for patient ingress and egress chair and wheelchair. List and demonstrate bed features for activities of daily living, or ADLs, positioning, and patient safety. To understand nighttime emergency concerns and issues. To choose the correct size bed frame and mattress for the patient and the facility. And discuss clinical and mobility considerations with bariatric patients. When repositioning or moving patients, both caregiver and patient safety should be considered. This training program will illustrate some of the features of an electric bed frame that can be used to assist with patient positioning and activities. The following quotes illustrate some of the concerns and issues with manual repositioning.
Today's nursing workforce average age is 44.6. Patients are heavier, acuity, age, and comorbidities are increasing. Staffing shortages are increasing, and ergonomic imperatives require patients to move through the healthcare system more quickly.
The technology and features incorporated in today's hospital bed frames has made them an intervention for patient and caregiver safety. Positioning features allow the patient and caregiver the flexibility to conform the bed for a ventilator dependency, feeding tubes, pressure injury prevention and treatment, combined with a therapeutic mattress, activities of daily living, or ADLs, and safe handling of the immobile and/or obese patient. Special positioning bed frames, like the Stryker frame and Circle electric bed, have been around for many years to treat specific patient injuries. However, most nurses do not think of the standard hospital bed as an intervention for prevention and treatment of certain conditions and complications, other than integrated therapeutic beds like low air loss or LAL beds, etc. MDs now order or have standard orders to raise the head of bed 30 to 45 degrees to prevent ventilator-associated pneumonia, or VAP, and 30 degrees for patients with feeding tubes. The raising of the head of the bed for prevention of one issue may put patients at risk for pressure injuries due to the friction and shear associated with migration caused by raising the head of the bed. Patient migration requires the patient to be moved up in bed to maintain proper alignment. The guidelines of the National Pressure Injury Advisory Panel, or NPIAP, on prevention and treatment of pressure injuries recommends that patients be lifted, not dragged, when repositioned. However, today's caregivers are older, patients are larger, and have higher acuity levels in post-acute settings than in past years. State, facility, nursing associations, and OSHA recommend no lifting policies or limits to the amount of weight a healthcare worker can lift to 35 pounds. So what is a caregiver to do to keep the patient in the correct position in bed? It is preferable to use a lift to move patients. However, if a lift is not available, healthcare workers should use good body mechanics and moving methods to transfer patients from stretcher to bed and bed to stretcher. Consider patient safety when moving patients from one surface to another. Be sure to lock wheels on both surfaces. Use good body mechanics and a lift system if available to reduce shear injuries to patients and back injuries to caregivers. Use transfer boards when possible. Notice the auto contour feature, which articulates the knee as the head rises to prevent patient sliding, decreasing the need for frequent repositioning or pulling up in bed. Repositioning patients manually is also associated with a high risk of musculoskeletal injury. Use lift equipment or Trendelenburg with a low-friction sheet if possible. Comfort chair, sometimes called cardiac chair position, is designed to raise the head of the bed, elevate the knees, and lower the feet to resemble and feel more like normal chair sitting. Comfort chair positioning is used for comfort, chronic obstructive pulmonary disease, COPD, to reduce reflux aspiration, possibly for ventilator-associated pneumonia, VAP. Comfort chair may also be used for preambulation acclimation of cardiovascular system, PACS, after long periods of bed rest to allow patients to acclimate to the upright position, decreasing the possibility of dizziness, fainting, and/or falls. There are concerns with the Fowler position. High Fowler's is associated with increased pressure injury risk, shear and pressure applied to sacral and ischial area, falls, and migration. Patients with large abdomens may feel uncomfortable pressure when their middle is compressed by the Fowler's position.
The semi-Fowler's position is the position of a patient who is lying in bed in a supine position, with the head of the bed at approximately 30 to 45 degrees. Upright at 90 degrees is full or high Fowler's position and can cause the patient to slide towards the foot of the bed.
It is also important to think about safety when patients are ingressing and egressing. Be sure the patient is stable, whether sitting or standing, before the next step to decrease risk of falling. Clinical considerations when patients are sitting or the head of the bed is elevated are: pressure on the sacral ischial area is increased while sitting, so reposition the patient often while up in a chair. Use chair cushions to reduce pressure on the ischial tuberosities. Keep the patient off pressure injuries if possible, or limit the amount of time pressure is applied. For more information on pressure injuries, see Clinical Education e-learning modules on SpanAmerica.com. When changing bed position, be sure the patient can reach the nurse call button, a common reason for falls, the TV remote, and phone, etc. A bed with a retractable frame, such as the Encore with Glide-A-Line, will keep the head of the bed aligned with the bedside furniture to reduce the risk of falling when accessing items. The NPIAP recommends that patients should be repositioned based on their risk level for pressure injuries. This includes keeping the head of the bed at or below 30 degrees, except for brief periods for meals, etc., to prevent migration sliding, which can cause shear stress to the sacral tissue. Patients at risk for heel injuries should have their heels floated off the surface using a foam wedge or pillows. Clinical considerations when moving patients from side to side or raising the head of the bed are that they can cause shearing. Frequent turning and repositioning should be done to keep the patient correctly positioned in the bed and prevent pressure injuries.
The use of side rails should follow the CMS, Centers for Medicare and Medicaid Services, and FDA, Food and Drug Administration guidelines and facility protocol. Details are available at this link, fda.gov.
For nighttime safety, the low bed position is recommended with a fall mat in position for patients that are prone to get out of bed. Half the falls in a study by Eileen Hitcho were elimination-related, patients leaving the bed unassisted due to incontinence or the need to toilet. Studies have found that inadequate lighting, lack of breaks, and room clutter contribute to falls. The Encore frame will lower to 7 7/8 inches and has adjustable underbed lighting. For emergency care and cardiopulmonary resuscitation, CPR, the bed frame should be placed in the flat position. Most beds will have an electric or hydraulic mechanism to facilitate a quick drop of the head of bed into a flat position for emergency treatment. If a dedicated button does not exist, use the staff or patient control button for head of bed articulation and hold it until the correct position is achieved. The type of mattress the patient or resident is on will determine if it needs to be deflated or a backboard used to perform CPR. If your bed has Trendelenburg and reverse Trendelenburg features, the uses are hypotension, insertion of central line catheters, surgical procedures to repair hernias or abdominal organs, to assist with repositioning patients up in bed with friction-reducing sheet when lift equipment is not available. Reverse Trendelenburg position uses are central line removal and to raise the head of bed for patients with large abdomens. The Fowler's position and elevation may squeeze the abdomen, which can compromise pulmonary function. Knees should be gatched or the foot of the bed raised. This use is usually in the acute care setting, but may be helpful in long-term acute care facilities or LTACs. When choosing a bed frame and mattress, it is not just about the patient's weight. Consider each of these factors. Weight. To avoid misunderstanding, verify that the bed frame's safe working load allows for the patient's weight and that the mattress is also rated for the patient's weight. All beds should have the safe working load indicated somewhere on the frame. Weight distribution. 350 pounds is the weight that usually triggers facilities to implement bariatric protocols. However, a 5-foot-tall 350-pound patient will require different equipment than a 6-foot-5-inch 350-pound patient. Height and width. Also consider whether the frame and mattress fit the patient. Some frames, like the Encore, have the ability to change width and length built into the frame or as accessories. This eliminates the need to change beds, but remember that a wider and/or longer mattress will be needed. Activity level. For patient safety, also decide whether a mattress with a raised perimeter may be needed. Consider microclimate management for patients with large or excessive skin folds when choosing a mattress.
Although obese and bariatric patients account for less than 10% of acute care facility census, injuries to caregivers involving bariatric patients accounted for almost 30% of staff-reported injuries.
Assess the level of assistance needed with the bariatric patient and evaluate the types of lifting and moving tasks required for activities such as bathing, eating, skin care, toileting, sitting, and ambulating. Caregiver issues, such as potential musculoskeletal injury, regulations regarding manual handling of loads, insufficient staff, and patient instability, are all potential challenges associated with repositioning of patients.
Determine the need for lift equipment based on the dependency levels of the patients. Algorithms were developed by the VA in 2003 to provide guidance.
Prevention and treatment of medical conditions is accomplished by a combination of medical expertise, medicine, therapy, and medical devices. This education program has illustrated the clinical, technical, and safety aspects of using a bed frame like the Encore as part of a comprehensive management program for safe patient handling and positioning.